Okay, we've arrived at the scene of a 70-year-old male, chief complaint being chest pain with a collapse. The patient has a history of a previous MI, and the patient's stating that the pain in his chest feels different. So the patient's cool to touch, he's pale, he's clammy. Primary survey is revealing the patient is breathing, he's maintaining a patent airway, however peripherally shut down, can't find radial pulses, and his carotid pulses are strong, bounding. Absent radial pulses, very likely for VT. He's on, he was complaining of the pain in the lazy boy, and we've laid him down supine. We've put a 3 lead on, and we're at this stage considering it's ventricular tachycardia. So we're just going to print off a strip now, just to confirm, rule out any differentials. Possible differentials of VT is we need to figure out what the cause of the VT is. So at this stage, I don't think the VT is secondary to any poisoning. If that were the case, we'd be administering fluids. The patient doesn't have a history of renal impairment, and he's not on dialysis, so we can also probably rule out the VT secondary to metabolic or electrolyte impairment. It's also important to take into consideration, as I said before, the cause of the tachydysrhythmia. So for example, AF, if that's secondary to something like sepsis, very important to rule out the primary cause first, because if you do cardiovert AF secondary to sepsis, the patient could die. But our main consideration now for this ECG is differentiating between VT and SVT with aberrancy. So as you can see on here, we have wide complex QRSs. We also have regular frequencies of the QRSs, and if there were presence of fusion beats or capture waves, then that would most likely indicate VT. Also, due to the patient's age and his heart history, VT with severe compromise is the most likely diagnosis as opposed to SVT. So we're going to treat this as VT and do a cardioversion. So after performing a range of vitals, we've found, as mentioned earlier, radial absent, cool, clammy, carotid pulse strong, and a rate of 170 approximately. I've done a blood pressure at 70 on 40. He's got a temperature of 37 and a BGL of 7.6 with a respiratory rate of 18. Due to this patient's severe level of compromise, so that can be determined by the hypotension and also the inability to obey commands, I'm deeming this a status 1, and we're going to call for backup straight away. So once that's underway, once the backup's on the way, I've also already administered an IV while the patient's got patent veins and a blood pressure, just in case we need to administer medications or if he deteriorates later on. Before doing anything, we're also going to have the BVM ready, oxygen that's going to be already hooked up, just in case we need to start manually ventilating the patient. We've got our suction here ready to go. So once the vitals are done, we're now going to pull out our cardioversion checklist. So we've definitely confirmed it's VT, and we've ruled out other possible diagnoses. So we're now getting the paddles, and we're placing these on the sternum and also the apex. So once we've done that, we're going to put the defibrillator into manual mode onto the maximum joules for an adult. If this was a child, pediatric, we would be phoning the clinical desk for them to tell us what joules to put it on. Once we're doing that, we're going to make sure that there's an R wave in every complex, and that there's a QRS, there's a detection symbol when we manually synchronize it above every complex. So I've already put it on lead number 2, and now we're going to print just to manually check that there is a detection symbol above every R wave. So as I can see here, we have the detection symbols above the R waves. So just checking the monitor again, checking the patient. We're now going to check the area, warn everyone that we're going to charge. Right, all clear, about to shock. Done. And once the shock has gone through, you're reassessing the rhythm, you're reassessing the patient's cardiovascular compromise. And as you can see, it seems like the patient is now in normal sinus rhythm. So we're going to reassess our ABCs, we're going to provide a scene update, and we're going to constantly monitor the patient. But otherwise, if administering a second cardioversion, we're determining that it's still synchronized.